Hello and welcome everyone. Today we'll be discussing the latest in the management of subarachnoid hemorrhage, especially those arising from aneurysms. Aneurysmal subarachnoid hemorrhage is a critical condition where bleeding occurs in the subarachnoid space due to rupture of an intracranial aneurysm. Despite being rare, it is associated with high mortality and morbidity. Early and effective management in the ICU is crucial for improving the patient outcomes. The main issues in this case are high global case fatality and morbidity rates, critical need for a prompt diagnosis and specialist care, and focus in ICU management to mitigate the complications like rebleeding and delayed cerebral ischemia. The incidence, it accounts for 2 to 5% of all strokes globally. The incidence has increased from 10.2 per 1 lakh population in 1980 to 6.1 in 2010. The demographics. There is a higher incidence in women than men, particularly as the age increases. Significant variability occurs across regions and population. The risk factors being hypertension, smoking, age and sex, that is more with women at higher age group. The impact of this is that it approximately affects 12% of the patients die before even reaching the hospital. Now, 90% case fatality rate remains quite high at around 30% for all hospitalized patients. Survivors often face significant functional as well as cognitive impairments. The clinical presentation. The symptoms are very classical: the thunderclap headache, the worst headache of life, nausea, vomiting, neurological features like confusion, vision abnormalities, focal deficits. The initial diagnostic step is a non-contrast CT. Then you do a lumbar puncture if the CT is negative, but clinical suspicion still remains high. CT angio is used to localize the aneurysm. The severity scales are used, that is the World Federation Neurosurgical Society scale, GCS, Hunter Hess scoring, Fisher scale. All these things help us in quantifying the severity of the disease. So as you can see here, once there is a bleeding, there are two consequences. There is a cerebral consequence and a systemic consequence. If it is very huge and there is an increased ICP which is also increasing rapidly, then it will definitely lead to a death. But the systemic consequences are sympathetic and parasympathetic cascade, which will affect your metabolic factors, and it will also affect your cardiac complications. The cerebrals are signs of early brain injury, and apart from that, later on you can have other secondary problems like vasospasms, hydrocephalus, seizures. All this thing can result in what is known as delayed ischemia. So early brain injury occurs within the first hours of the hemorrhage, involves cerebral edema, microcirculatory alterations, oxidative stress and inflammation. It leads to neuronal damage and raised ICP. Initial stabilization in ICU is ABCD, first airway, that is intubation, neuroimaging, non-contrast CT, hemodynamic stability, multidisciplinary approach involving the neurologist and the neurosurgeons as well as interventional neuroradiologist to make a treatment plan. Treatment priority is preventing a risk of rebleeding and managing the complications. So how do we prevent a rebleeding? This is a critically important part because rebleeding significantly worsens outcomes and increases mortality. It typically occurs within the first 24 hours after rupture. Strategies are to prevent rebleeding are early aneurysm repair, surgical clipping, that is directly closing of the aneurysm via open brain surgery, or you can do endovascular coiling. This is done by the neurointensive. Now the next is endovascular coiling, which is done by the neuroradiologists. This is minimally invasive procedure where a coil is introduced to occlude the aneurysm from within. The aim is to perform within 24 hours, but repair up to 70 hours can be effective if early repair is not feasible. The antifibrinolytics, initial use to stabilize the clot. However, prolonged use has shown limited benefit and increased risk of delayed cerebral ischemia. Recent studies indicate no significant outcome with ultra early tranexamic acids. Now, blood pressure management, this is very important. Control hypertension to reduce the chance of rebleeding. Target a systolic pressure less than 160. Tailor it to the patient's need. Guidelines recommend to secure the aneurysm as soon as possible to reduce the risk of bleeding and maintain the hemodynamic stability. So these are the various complications, that is rebleeding, seizures, hydrocephalus, intracranial hypertension, and delayed cerebral ischemia. We will deal with each one by one. The next is management of the hydrocephalus. In this, accumulation of the CSF occurs. Now, common in SAH, it can be acute or even delayed complications. The types and mechanisms, there can be acute hydrocephalus, which is because of the obstruction to the CSF flow, or there is a chronic hydrocephalus because of the persistent CSF flow disturbances. Clinical presentation is decrease in the consciousness, lethargy, confusion, downgazing, deviation in severe cases, bradycardia and hypertension can also occur. Treatment options we have are the EVD, that is you put a drain to drain out the extra fluid, provide immediate relief, and also helps us in measuring the ICP and reducing the ICP. Important to monitor and adjust drainage. Lumbar drainage can also be done. This is useful in cases without significant interventricular blood, less invasive than EVD. The other thing that we can do is shunting. This can be considered for long-term management if there is a chronic case of persistent involve permanent diversion of the CSF to the peritoneal cavity. The timing, initial CSF diversion, so in clinical signs of hydrocephalus, careful monitoring of ICP and neurological status is essential to adjust treatment and avoid complications. Now, aneurysm treatment and strategy. The treatment objectives are rapidly secure the ruptured aneurysm to prevent rebleeding, minimize the risk of delayed cerebral ischemia and other complications. Treatment options are, as we have discussed, there is a surgical clipping which involves a craniotomy to place a clip at the base of the aneurysm. It is preferred for aneurysms that are easily accessible, have complex shape that are difficult to treat by endovascular route. Advantages include direct visualization, potential for complete aneurysm obliteration is there. Endovascular coiling is other option that we have. It involves inserting a coil into the aneurysm and less invasive than clipping, makes it suitable for patients who have very high risk for surgery and have aneurysms in difficult to assess locations. Is generally associated with quicker recovery and reduced immediate post-operative complications. The factors that influence the choice are patient specific, that is age, overall health status, the patient's ability to tolerate a big surgery, aneurysm specific like the location and the size and the morphology of the aneurysm. Clinical condition, that is severity, presence of other complications and timing of the rupture can also affect the decision process. And obviously the facilities available in the institution will definitely matter. Timing of the treatment, early within 24 to 72 hours. Balancing urgency with the patient stability is crucial. Outcome is clipping, often preferred for long-term durability in younger population. Coiling is for older people with high risk of surgery. Now, how do we prevent this delayed cerebral ischemia? The risk factors are poor initial clinical condition by the scorings that we have already seen, high radiographic grade, other factors being female sex, smoking, hyperglycemia, presence of an hydrocephalus. Prevention can be done by nimodipine, which is given orally, and maintaining euvolemia, avoiding hypotension. Detecting and monitoring. How do we know that this is actually happened? Regular neurological assessment is crucial. Imaging techniques like CT angio will help, transcranial Doppler, advanced monitoring methods like EEG, brain tissue oxygenation is crucial in these cases. So management approaches, hemodynamic augmentation, induced hypertension to enhance cerebral blood flow, commonly using vasopressors like norepinephrine. Endovascular therapy, intraarterial infusion of vasodilators and balloon angioplasty for severe vasospasm. Additional is exploration of the anti-inflammatory strategies and other non-intervention or a matter of ongoing research. So here it has been clearly demarcated. You must do first rule out the other causes that can be the reason for the lowering of the sensorium. Then you look for the neurological monitoring, because if you're doing it regularly, you will detect these changes. And finally, you can do for the imaging. The next important complication is ICP, which can raise because of various reasons, and elevated ICP is a real poor outcome measure. So monitoring ICP becomes a very crucial factor. The indications to ICP monitoring are severe cases, that is a GCS less than 8, patients with neurological deterioration or significant cerebral edema, acute hydrocephalus and significant intraventricular hemorrhage, and during perioperative period when CSF drainage is required. The methods is first is by putting a ventricular catheter, which is the most easiest method that is available and the gold standard. Apart from that, you can put subarachnoid bolts or intraparenchymal sensors, Managing strategies for elevated ICP are CSF drainage, that is via EVD to relieve the pressure, hyperventilation, osmotherapy, sedation and analgesia, intracranial pressure. The advanced therapies are hypothermia, barbiturate coma, decompressive craniectomy. Thresholds and targets are very important. The ICP target should be kept up around to keep the ICP below 20 or 22. Recent evidence suggests a need to individualize ICP based on patient specific factors and duration of the elevated ICP episode. The next is seizure management. This is very important. Seizure can occur at any time over here, and the risk factors of it are old age, ruptured aneurysm, especially in the anterior circulation, and presence of ventricular drain. Seizure types, it can be convulsive seizures or non-convulsive seizures, and you can also go into a status epilepticus. So monitoring is important. Continuous EEG is required for non-convulsive ones. Periodic EEG monitoring is required to detect subclinical seizures, especially if the sensorium is not improving. Clinical observation, regular neurological assessment to detect new onset or changes in seizure activity. Management strategies are prophylactic anti-seizure measurements, that is no routine recommendation due to lack of evidence, and benefit and potential side effect of these therapies may be considered in high-risk patient during the acute phase. But currently there is no such recommendation to give prophylactic drugs for in these cases. Treatment of seizures can be done obviously because of acute management is required. First is benzodiazepine, followed by the longer acting ones like phenytoin and levetiracetam. Avoid prolonged use of phenytoin due to potential adverse effects. Individualize the therapy based on patient's risk factor and tolerance. Long-term management, continuous management, because if there is recurrent seizure or any identified risk factor, gradually taper it. Considering in special cases, electrographic seizures, even without clinical manifestation, these require treatment to prevent further brain injury. Periodic discharge often observed in EG, this is significant need to be treated, is still a matter of debate. Regarding the cardiac complications, the subarachnoid haemorrhage can result in an intense sympathetic activation and catecholamine release. These complications are resulting in mortality and morbidity, and the types of cardiac complications are arrhythmias, commonly are tachyarrhythmia, atrial fibrillation, ventricular tachycardia, ventricular fibrillation, result from disruption of the normal cardiac conduction due to the autonomic disbalance. The next is myocardial dysfunction. This can be because of the stress of the high catecholamine levels, often presents with symptoms of mimicking myocardial infarction. Myocardial ischemia can as such occur itself, that is acute ischemic episode because of the vasospasm, increased risk in post-op hemorrhage cases. Now, diagnosis and management is important. You need to do regular ECG monitoring, cardiac enzymes monitoring, echocardiography, and the management strategies here are arrhythmia management, which you correct the electrolytes. If it is to be corrected, administer antiarrhythmic drugs. Myocardial dysfunction care is required, where you support the heart by doing a proper fluid management. You can monitor signs of heart failure and adjust the treatment accordingly. Treatment of ischemia can be done, collaborate with cardiology over here, addressing the underlying coronary disease. Finally, the pulmonary complications, they are also quite significant and occur quite frequently with subarachnoid hemorrhage. These complications are pulmonary edema, pneumonia, and ARDS. So the non-cardiogenic pulmonary edema triggered by sudden increase in intracranial pressure leading to surge in catecholamine, causing a leak in the lungs. It presents at acute respiratory distress with rapid onset of breathing difficulty and hypoxemia. The next is pneumonia, where the patient can develop aspiration because of the poor swallowing reflexes, or VAP when the patient is on long-term ventilator. ARDS, as any of these complications, can aggravate into a bilateral involvement and ARDS. Now, diagnosis and management, chest x-ray, CT scans, blood gas analysis, clinical examinations. So in the management strategy for neurogenic pulmonary edema, you need supportive care with oxygen and ventilation, use of PEEP, and careful fluid management strategies. For pneumonia, you need antibiotics and regular oral care, minimize sedation. For ARDS, standard management of lung protective ventilation, monitoring for barotrauma, and in severe cases, ECMO. The next important management is metabolic and fluid electrolytes, which there is a long of derangement because of the autonomic disbalances. So in the fluid management, the goal-directed therapy is to use dynamic indices for giving fluids, aim to keep a euvolumic state. Invasive monitoring may be required, art lines, pulmonary artery catheters. Balancing cerebral and systemic needs is very important over here. Avoid aggressive management of fluid. Electrolytes, common imbalances are hyponatremia, hypokalemia, hypomagnesemia. Correct them effectively and monitor and replace them as and when required. Avoid overtly rapid corrections because it is going to cause more cerebral damage. The next is glucose control, which is vital. Hyperglycemia prevention is important to prevent secondary damage. The goal is 140 to 180. Sugar, nutritional support, prefer enteral route over parenteral, ensure adequate calories and protein. Temperature, avoid fever, reduce and keep normothermia. You can use antipyretics, cooling blankets, and other methods. So these are the other complications that we have discussed here. Manage the fever, keep the hemodynamics okay, respiratory management, the electrolytes management, and finally DVT prophylaxis. Start DVT prophylaxis as soon as the aneurysm is secured. Regarding the long-term management, over the past decade, the advancement in the management of SAH has improved with better survival rates. Even patients with initially severe presentation can now achieve favorable recovery parameters. Functional recovery, which is the most important thing, approximately 1/3 of these patients have very good functional recovery. So functional assessment is important by modified Rankin or Glasgow outcome scales. And cognitive and psychological impact is also very important. Many survivors face long-term cognitive deficits like memory problems and difficulty in execution functions. These deficits can significantly affect quality of life and return to work. Psychological issues like anxiety, depression, fatigue are common, requiring ongoing support. And the quality of life, which is the most important outcome, despite physical recovery, a significant proportion of the patients report reduction in their quality of life. So these aspects must be kept in mind. And finally, you must have a very good support system and rehabilitation program, which is essential for addressing their long-term needs. Thank you for your patience.